Here's a detailed, comprehensive, and academic-style explanation of leukocyte adhesion deficiency, LAD, covering all 19 sections, with clear headings and rich content suitable for assignments, reports, or nursing presentations. Leukocyte Adhesion Deficiency, LAD. 1. Introduction. Leukocyte adhesion deficiency is a rare congenital immunodeficiency disorder that affects the immune system's ability to fight infections. It occurs when white blood cells, particularly neutrophils, cannot properly adhere to blood vessel walls and migrate into infected or inflamed tissues. This defect results in recurrent bacterial and fungal infections, poor wound healing, and an absence of pus formation at infection sites. Although the total white blood cell count is markedly increased, these cells are functionally ineffective because they cannot reach the site of infection. LAD is classified as one of the primary immunodeficiency diseases, PIDs. Number 2. Definition. Leukocyte Adhesion Deficiency, LAD, is defined as a genetically inherited immunodeficiency disorder characterized by defective expression or function of adhesion molecules, integrins or selectin ligands on leukocytes, leading to impaired leukocyte migration, adhesion, and chemotaxis into inflamed or infected tissues. The result is recurrent, severe infections without pus formation, delayed wound healing, and persistent leukocytosis. Number 3. Etymology. Leukocyte, derived from Greek leukos, white, and ketos, cell. Adhesion, from Latin adhere, to stick to or cling. Deficiency, from Latin deficere, to lack or fail. Together, the term refers to a lack of white blood cell stickiness, meaning the inability of leukocytes to attach to vessel walls and move to infection sites. Number 4. Epidemiology. LAD is extremely rare, with an estimated incidence of 1 in 1,000,000 live births worldwide. It affects both males and females equally, since it follows an autosomal recessive inheritance pattern. No particular racial predilection is observed, but the disorder is more common in populations with consanguineous marriages due to increased genetic homozygosity. Type 1 LAD is the most frequently reported form, about 75 to 80% of all LAD cases. Most affected infants present with symptoms in the neonatal period or early infancy. Number 5. Types. There are 3 major types of LAD, each caused by distinct molecular defects. A. LAD type 1, caused by mutation in the ITGB2 gene, chromosome 21q22.3, which encodes CD18, the B2 integrin subunit. Leads to defective expression of integrin molecules, MAC1 P15095, most common and severe type. B. LAD type 2, caused by mutation in the SLC35C1 gene, leading to defective fucosylation of selectin ligands. This impairs leukocyte rolling and migration through blood vessels, characterized by recurrent infections, short stature, developmental delay, and Bombay blood phenotype, H deficiency. C. LAD type 3, caused by mutation in the FermT3 gene encoding kinlin-3, affecting all beta integrins. Results in both defective leukocyte adhesion and platelet aggregation, leading to bleeding disorders in addition to infections. 6 causes. Genetic mutations inherited in an autosomal recessive pattern. Both parents must carry one defective copy of the gene. The specific causes are LADI, ITGB2 gene mutation, BD2 integrin defect, LA2 SLC35C1 gene mutation, defective fucosylation, LA3 FermT3 gene mutation, defective kinlin-3 protein. 7. Risk factors. Consanguineous marriages, parents related by blood, positive family history of immunodeficiency or early infant deaths due to infections, carrier parents with mutation in ITGB2, SC35C1, or FermT3 genes, ethnic or geographic clusters where recessive mutations are more common. Number 8, complications. If untreated, LA can lead to recurrent life-threatening infections, skin, lungs, GI tract, urinary tract, sepsis and septic shock, chronic non-healing ulcers and periodontal disease, delayed wound healing, growth retardation due to chronic illness, severe gingivitis and tooth loss, bleeding tendency in LAD 3, early childhood death from overwhelming infections. 9. Pathophysiology. The immune response depends on leukocyte migration from the bloodstream to sites of infection. This process involves 1. Rolling adhesion. Leukocytes roll along the endothelium via selectins. 2. Activation. Chemokines activate integrins on leukocytes. 3. Firm adhesion. Integrins CD11, CD18 bind to ICAMs on endothelial cells. 4. Transmigration, diapedesis. Leukocytes move through the endothelium into tissues. In LAD, defective or absent integrins, selectin ligands, prevent leukocyte adhesion and transmigration. Neutrophils remain trapped in the bloodstream, marked leukocytosis. Tissues cannot receive immune cells, no pus, no inflammation, and poor healing. Number 10. Stages, severity levels. Although LAD has no fixed stages, it is categorized by severity. Mild, CD18 expression 30%. Fewer infections, survival into adulthood possible. Moderate, CD18 expression 2 to 30%. Frequent but manageable infections. Severe, CD18 expression 1%. Life-threatening infections, early death in infancy without treatment. Number 11. Signs and symptoms. Delayed separation of umbilical cord, 21 days after birth. Recurrent bacterial and fungal infections, skin, lungs, GI tract, urinary tract. Absence of pus formation despite active infection. Leukocytosis, white cell count often 20,000 mm. Poor wound healing. Chronic ulcers and skin abscesses. Severe gingivitis and periodontitis. Failure to thrive or growth retardation. Bleeding tendency, LA3. Developmental delay and Bombay blood group, LA2. Number 12. Medical diagnosis. Diagnosis is based on clinical suspicion, laboratory tests, and molecular confirmation. A. Clinical findings. Recurrent infections with minimal inflammation or pus, delayed cord separation, poor wound healing. B. Laboratory investigations. CBC, marked neutrophilia and leukocytosis. Flow cytometry, reduced or absent CD8, CD11 expression on leukocyte. Fucose uptake test, abnormal in LAD2. Genetic testing, mutation in ITGB2, SLC35C1, or FERMP3. Neutrophil adhesion migration assays show functional defects. Number 13. Nursing diagnosis. Risk for infection related to defective immune response. Impaired skin integrity related to chronic ulcers and poor wound healing. Delayed growth and development related to chronic disease. Anxiety and fear related to frequent hospitalization and illness. Deficient knowledge family related to disease process and home care. Number 14. Medical management. Prompt and aggressive treatment of infections using broad-spectrum antibiotics and antifungals. Hematopoietic stem cell transplantation, HSCT, the only curative treatment for LAD-I and LAD-3. Granulocyte transfusions during severe infections, temporary measure. Recombinant granulocyte colony stimulating factor, GCSF, may increase leukocyte counts. Fucose supplementation is effective for LAD-2. Gene therapy is under clinical trial for LAD-I. Number 15. Nursing management. Maintain strict aseptic techniques to prevent infection. Perform regular wound care with sterile procedures. Monitor vital signs and infection indicators, fever, WBC, culture results. Encourage proper nutrition to promote tissue healing and immune function. Educate family about early recognition of infection and importance of follow-up care. Provide psychological and emotional support to family members. Administer prescribed medications, antibiotics, antifungals, GCSF, accurately and timely. Support post-transplant care if HSCT is performed. Number 16. Treatment options. Treatment type, description curative therapy. Hematopoietic stem cell transplantation. HSCT replaces defective immune cells. Experimental therapy. Gene therapy corrects defective ITGB2 gene. Supportive therapy. Antibiotics, antifungals, GCSF, wound care. Dietary supplementation, oral fucose therapy for leak 2, blood transfusion, granulocyte or platelet transfusion in severe cases. Number 17, psychosocial interventions. 1. Family counseling, to help parents cope with chronic illness and stress. 2. Genetic counseling, to educate parents about inheritance and recurrence risk. 3. Support groups, connect families facing similar challenges for emotional support. 4. Health education, teach infection prevention, hygiene, and nutrition. 5. Psychological therapy, for anxiety, fear, and depression related to long-term illness. 18. Prevention, genetic counseling and carrier testing for at-risk families. Prenatal diagnosis using chorionic villus sampling or amniocentesis. Avoid consanguineous marriages in families with known history. Newborn screening programs in high-risk populations. Early diagnosis and HSCT can prevent severe complications. Number 19. Conclusion. Leukocyte adhesion deficiency is a rare but potentially fatal immunodeficiency caused by defective leukocyte adhesion and migration. It manifests as recurrent infections, poor wound healing, and absence of pus despite high leukocyte counts. Early diagnosis through genetic and immunological testing is essential. With advances in hematopoietic stem cell transplantation and gene therapy, long-term survival and quality of life have improved. Comprehensive medical, nursing, and psychosocial care are crucial for managing affected individuals and supporting their families. Thank you. Have a nice day.